Through that. So welcome for this evening. We're going to be talking with Dr. David Aboulafia about the evolving issues around cancer screenings and treatments for people living with HIV. So I'm glad you're here. For people in the room, there's pizzas and there's drinks. Please help yourself. There's also a copy of the slides, which you might want to have. And the next thing that I do have here for everyone is the first point of today. Before I'm going to go through some announcements. And my first announcement is, I don't know if you know, but it's been 40 years since the creation of a document called the Denver Principles. And you may or may not have heard of this document, and I wanted to refresh our memories of it because it has changed healthcare for everyone. A group of 11 gay men who are living with HIV made a proclamation at the 5th Annual National Lesbian and Gay Health Conference, which was being held in Denver, which is why they call these things that they wrote the Denver Principles. But it's really the start of the people living with HIV self-empowerment, and that whole idea of your healthcare is in your hands as much as your doctor's hands. In fact, if a doctor ever asks you about changing medicines, or if you want to go on a medicine, you can thank these 11 individuals, because they were the ones that sort of put their foot on the ground and declared that there were certain things that needed to change. So they outlined 17 principles that were covering everything from healthcare decisions to civil rights to sexual conduct. And it started off with these famous words: we condemn attempts to label us as victims, a term which implies defeat, and we are only occasionally patients, a term which implies passivity, helplessness, and the dependence of the care upon the care of others. We are people with AIDS. So there's a picture of the 11. Of all 11, some of them died a few months after this. The man who's standing above the T and fighting for our lives, Richard Berkowitz, he's the only man who's still alive today. And he was famous for writing safe sex pamphlets or safer sex pamphlets back in the day. So the things that they demanded in these in this sort of Bill of Rights, this Declaration of Independence for HIV, they demanded that physicians see their patients as whole people and provide accurate information. They believed their opinion on their care should be awarded equal weight as the opinion of the physician. They asked all people to fight against AIDS discrimination in the workplace and in housing. And if you remember those bad old days, those are really two of the major things that people were dealing with, not only just being gay for that, but also having HIV. You would lose your job, you could be kicked out of your housing. They advocated for full and satisfying sexual and emotional lives as anyone else for people with HIV and AIDS. So if you think about it, that was really radical at the time, because people were looking at people living with HIV or AIDS as a, not only as a death sentence, but as a diseased pariah, people who were going to spread the disease. And so to say that you could have a full and satisfying sexual life and emotional life as well is just really radical at a time when the hatred was so fierce towards people. And I just wanted to remind you that that's 40 years ago. I brought a copy in the room here of the Denver Principles for you all to take a look at it. It's a simple one-page piece of paper that changed things forever. So if you ever have any advocacy issues that you've been dealing with, the fact that this CAB even exists, it's all as a result of these 11 men who stood up and said, no more. We are people and we deserve dignity and respect, and we need to be at the table. If there are going to be decisions about us, we need to be there. Nothing about us without us is the whole phrase that comes from that. And so that's the start of this. And the world has these 11 men to thank. And they did it in a hotel suite, not a suite where they were sleeping, but just one of those sort of like off the main conference room. They just had it and they wrote these together at that time, and they've changed the world. Also, I wanted to go through this with you very quickly. We have some numbers, and I just wanted to share them with you. So we've had some pretty good enrollment numbers And I just wanted to share with you the numbers because I'm not used to seeing numbers like this, at least not for a while. If you remember, we had the illicit study, which was the study of CMV, giving the CMV vaccine to people. We had 8 people enroll in that. The slim liver study, which was about trying to treat non-alcoholic fatty liver disease. We had 5 people enroll in that. The Do It study, which was about the excessive weight gain on the newer medicines and switching them to a doravirine to see if that helps. We had 11 people. Injectables Plus, we had 4 people, and that's where we gave people not only the injectable cabotegravir, but a monoclonal antibody as well to see if that would help. We had 2 people in our acute Hep C study. The COVID study we did, which was looking at many different outpatient treatments for people living with COVID. We had 34 people here locally enroll, and we have a current study for Mpox, and we've had 3 people enroll in that. And so these great numbers, like the very first one, I just want to point out there, that illicit study, remember, these are all small phase 1 trials. So that 8% was almost 20% of the total enrollment coming from our site, coming from Seattle. And I just think it's all because of you guys helping us by helping us perfect our message, but also I know a lot of you often would respond when we went over it as a CAB and would call in or tell people about it. And so it really helped. And so I think that is a testament to you all. And I wanted to just thank you for doing the work that you've done helping us. And I wanted to kind of share those numbers because I think they were pretty good. I also just wanted to quickly remind you that we won't have a meeting next month. I will be at the IAS meeting in Brisbane. And so we will resume again in August, actually August 22nd, and it'll be here again in Pierce, Seattle, and as well virtually. So those are all my announcements. I just wanted to give you some things to think about. And I wanted to turn over the floor to David. So please welcome David. And here's your first slide.
Thank you, Michael. I'm trying to think maybe it would be better for me to.
You want to sit here? Sure, go ahead.
And then I think I can probably just.
I was going to say, yeah, so you should, if you can't find it, you just got to get the thing and then you can just there.
From here?
You should be able to, but if it doesn't work, then you have to go.
And is there a way to blow that up? You know,
it's still like
really hard for people.
I know, but why is that's weird. It's like not.
Yeah.
Okay, hold on. Can you guys see it? I mean, I did print off copies for everyone so they can.
It's printed so tiny.
I know, sorry.
It's hard to be turned to light stuff.
Okay, but it's just like not showing us what's on the screen. For people online, we're having troubles with what people are seeing in the room. What you're seeing here on your screen online is not what we're seeing up here. We're seeing the let's see. So how would I?
Yeah, it is weird.
I don't even know how. Like, it's not showing like what is up there. All right. Well, can we try to go through with this? Let's see if that works. That you guys, yeah. I just want to make sure you all can see a little bit.
So you guys, I'm going to sit by the computer just so it's kind of awkward because I can't easily see you guys in the room and stuff. But if someone starts to snore, I'll throw a little pizza at them.
Right. Remember, if you have a question, just raise your hand. And online, we're not able really to see your chat hands raise up. So if you would just interrupt politely saying, excuse me, I have a question, that'll help us. Okay.
So greetings, everybody. My name is Dave Aboulafia. I'm a cancer doc at Virginia Mason. I've been in the HIV sphere for 30 years with a focus on immunodeficiency, viruses that cause cancer, blood disorders, and anything to do with HIV. And Michael invited me to come today to talk about generally, in general terms, what cancer is, how does it caused. I'm going to give a very little bit of information about treatments and how they're changing. And also, and perhaps the focus of this is leading up to how to screen for cancer, what kind of things should all of us be thinking about as providers and of course as patients as well. So thank you for inviting me, Michael. I really appreciate it. I have nothing to declare. So when we talk about cancer, I think that most people assume that cancer is related to genetics. And in truth, genetics, as we think of passing on a bad gene from one generation to the other, accounts for a very small number of cancers. we're used to thinking about BRCA1 or BRCA2. Those are genes that promote breast cancer, ovarian, endometrial cancer. We know that there are families at higher risk for pancreatic cancer because of inborn genetic errors. But most of the stuff that we look to that cause cancer come from the environment. And I think as we're becoming really painfully aware of climate changes and what the repercussions are, we're seeing dramatic changes and an appreciation of how factors in the environment can promote cancer. I think the easiest one, and we can look at this slide and say, tobacco is, at the very top of that list of things that we could prevent. It's not always appreciated, but diet, and in particular obesity, is highly carcinogenic. And when we think about breast cancer and when we think about colon cancer, diet is really, really important, as well as how much people may weigh relative to their height. Infections, as I'll mention in a minute, come for a minority of them. It's not a small minority, 15 to 20%. And if we think of infections, we could think about hepatitis B contributing to liver cancer, hepatitis C. A little known virus is HTLV1. And kind of a trivia, back in the 1970s, when they were trying to discover what was HIV, they found this virus called HTLV1, and they thought that was the virus that caused HIV. It took a couple years before it was discovered that what we now know as HIV-1 was the cause of HIV infection. HTLV-1 can cause leukemias, it can cause lymphomas, and in southern Japan, this is the #1 cause of cancer, but thankfully very unusual in the rest of the world. We also appreciate that radiation is a big problem. And when Chernobyl blew up and scattered radiation across Europe, back in the, I think it was 1980s, 1990s, there was a whole belt of thyroid cancer that followed in its tracks. And then we also realize now that cortisone levels, stress, anxiety can definitely be a risk factor for cancer too, although not commonly appreciated. I mentioned that there are viruses that can cause cancer. HIV is not one of them. We don't think of HIV as oncogenic, meaning that it can cause cancer, but we do think of that HIV can cause the substrate where other viruses can promote cancer. And as I mentioned, hepatitis B is a big one. HHV8 or Kaposi sarcoma herpes virus, which is the virus that causes KS, is one. Epstein-Barr virus is a huge one. And EBV is the virus that is kids, when they get sick with what's called the kissing disease or mononucleosis, rarely it can contribute to lymphomas and other types of cancer. And Merkel cell virus is, yeah.
I'm sorry. The previous slide, you had stress and lack of physical activity. I can understand stress, but lack of physical activity really can cause cancer.
It can. And so I think what we're understanding more and more that there are body types, if you will, that have placed people at higher risk. And when you are not moving, when you're not exercising, and you're putting on weight, that increases certain cancers. I mentioned colon and breast as two extremes. On the other hand, people who have unusually thin body habitus, have very low body fat, may be at higher risk for other types of cancers like esophageal cancer. And it's increasingly understood that it relates to the compensatory hormones that the body produces when you're wasting muscle, or if you have so much fat that you have very high levels of different hormones. Make sense? Yeah, a little bit. It's not something that's usually stressed, but definitely risk factors. Merkel cell virus is a really unusual virus. One of the researchers here at the University of Washington has done the most research with it. It's a skin tumor, but it's a very deadly one. It's kind of like melanoma. And we're still looking at other types of cancer that can be associated with this Merkel cell virus. I don't know. Does anyone recognize that picture? Anyone know? Yes. And what's that person's name? Does anyone know? Elizabeth Holmes. Elizabeth Holmes just got sentenced to prison for defrauding investors and claiming one thing and doing another. She had gained notoriety about 10 years ago as a leading female executive, a kind of a trailblazer. And she had supposedly patented a technology that with one drop of blood, they could do hundreds of different tests. There's a great documentary I saw on Netflix. It's called Fake It Till You Make It, which is, I guess, the ethos among a lot of people in this bio field, and was originally coined by Thomas Edison. And it turned out Thomas Edison was a great liar, and he desperately needed money to invent the light bulb and other things. And he would go around telling people that he had already created the light bulb, but he needed more money. And it was kind of like this. He said, fake it until you make it. And once you make it, then you can promote it. Well, she had claimed that she could do all kinds of tests from a drop of blood. She had very famous people invest in her company. At one point, her company was worth like 500 billion. I mean, it was crazy, $500 billion. And it kind of crashed rather spectacularly. I mention it though, because what she was claiming to do is now becoming a fact. And we can do a remarkable amount of cancer-specific studies from a drop of blood. And in the next couple years, instead of doing necessarily CT scans or colonoscopy to screen for people, we are going to be doing drops of blood and looking for DNA from these cancers that shed their specific DNA into the blood. It's really quite remarkable. We're just beginning to do it with certain cancers as we follow them through treatment, but you can imagine how much better that might be. The one study, they found that measuring DNA from cancer cells in the blood was about 3 to 6 months faster than seeing something on a CT scan. Wow. So again, the ability to find something before it's really causing problems. Of course, when we talk about cancer screening, we talk about chest x-rays. On that picture on the left next to Elizabeth Holmes, you can see a circle. That's a lung cancer that's showing up. And I know Michael had a speaker on lung cancer screening, and I'm going to take a couple minutes to talk about that too. And then we have more conventional modalities. This baby in Africa is getting an ultrasound looking for swollen lymph nodes. And in Africa, very hard to have technology that costs a lot like a CT scanner. And of course, that woman looks like she's going into a CT scanner. If you've ever been in one, it's kind of a trip to be in there. You're literally like in a casket and this thing is whirling around you and it makes a really loud noise and you can't move for like 30, sometimes it's up to 30 minutes. For some people, a really disturbing kind of test, and how great it'll be to just take the prick of blood and be able to do those kind of studies in that way. The other thing I wanted to emphasize on this test, on this slide, is that the risk of cancer goes up exponentially as we age. And in this slide, you see two graphs. One shows the rate of breast cancer going up as people across that x-axis at the bottom age. And the same is true with colon cancer. So if we look at colon cancer, the difference between age 20, which of course is a very rare age to get colon cancer, and age 80 is about 300-fold higher. And the thought is that as we age, our genetic material is getting bombarded with radiation, with, abnormal hormones that our body is producing, clearly getting associated with carcinogens. And there's a cumulative hit that can cause mutations that can lead to cancer. And so we don't usually screen young people for cancer. We usually think about it starting at a certain age. In the anchor study that Jeff was so important in, the age that they began screening was 35. And the reason they didn't screen earlier is because they thought that would be such a low yield, so unlikely to pick up cancer. Well, that's weird. So on my thing, it doesn't show a picture.
I know, but go again, the successful lesion is the next one.
Yeah, okay. Oh, okay, got it. All right. So, you guys, some people do seem to age better than others, and these are kind of iconic figures from from the public who have just like over the years didn't seem to age much at all. Sophia Loren was gorgeous. Cary Grant was making movies as a leading man well into his 60s. David Beckham, Denzel Washington. These are people that seem to know something. Maybe it's a good plastic surgeon, but something that the rest of us aren't so aware of. And I don't think it's usually spend a lot of time, but there are also people that have aged not so well. And these are examples of a couple folks who you may know. Nick Nolte was, what was it used to be? People magazine, the sexiest man alive. He was that winner like 30 years ago. Brendan Fraser just won an Academy Award for really powerful performance. And it's hard to imagine Nick Nolte Jack Nicholson at the bottom there. So it's a joke and it's meant to be funny, but I think we can really see, yeah, there are differences in how people age and how well they stay healthy and what they do to stay healthy. I think I'm always amazed. I mean, we're not far from Ballard and we have a lot of Norwegians here in the Northwest, and they do seem to age very, very well over the years. They, sit in straight back. They have lesser risks of osteoporosis and some other things. And you can imagine all the lifestyle factors that can go into that. So poor diet, stress at work. If you live in certain areas of the world, you're going to be, faced with pollutants every single day that are highly carcinogenic. And we don't have to think of China or India. I'm from Michigan. Flint, Michigan had their water supply contaminated in a really disastrous way. And the number of terminated pregnancies, miscarriages went up dramatically. We're seeing much higher incidences of cancer. A lot of times where we have these industrial waste accidents, it takes about 10 to 15 years, but we see a huge spike in cancer after that. So this is something you guys already know about, and that is that our HIV population is aging. People are living longer. And I think it was probably about 10 years when we had a magic mark of 50 as the median age for HIV. And as this keeps going on and people live a normal lifestyle, we're now seeing this aging population. And as we said, there are already inherent risks of cancer, but the biggest one is just being lucky enough to live long enough. So I think that's kind of a context for some of this other stuff. And so we had, this was in the New York Times in 2008, but a couple of years ago during COVID, the Seattle Times ran a really great article on the, I think it was the front page, but they singled out a couple people who had been long-term survivors of HIV, and they talked about how COVID in that early phase seemed a lot like the early days of HIV. But they also, in the article, delved into how these people had been living, because all of them had been there in the early years of HIV. And it was a pretty powerful thing. And this article was, I think, the first of many like it, where it just profiled people who were not really old. In this case, they were in their 50s and 60s. And their biggest complaint was that they were taking more medications on a daily basis than their parents were. And ironically, at their 50s and 60s, they were experiencing a lot of the same medical problems, like osteoporosis, like cancer, like heart attacks, like stroke, than their parents who were 20, 30 years older. So we've long associated HIV with a cancer risk. And back when I first came to Seattle, Michael, when I first met you, I couldn't see all the people who had cancer here. I mean, we were filled completely in the clinic, dozens and dozens of people with KS, lymphomas. And in those days, we said that about 30 to 50% of people were destined to either get Kaposi sarcoma or lymphoma in what was a very abbreviated lifespan. That's no longer the case. And you guys are all living examples of what HIV meds can do and how it's changed this trajectory of AIDS so profoundly. It is, yeah. Yeah, so Michael was, you're so astute, you pick up everything. But we had years ago when Bailey was opening up in the early phase, they commissioned 2 photographers to document what was going on at Bailey. And this was one of the things that this husband and wife team took pictures of. So, one of the things I want to say is, even though I'm harping on cancer in an older group, we're definitely seeing cancer in younger patients too. And that's going to have implications when we do talk about screening in a couple minutes. That photograph on the top left, does anyone know who that is? Did anyone see? Oh, yeah. Yes, it's Chadwick Boseman.
Oh, Chadwick.
Yeah. So Chadwick was a kind of an up-and-coming superstar, African-American actor. He starred in the Black Panther. His career was just beginning to take off. He actually died from colon cancer at 43 years old. And really, I think his case typified, and he was working to the very end. Most people, including members of his family, didn't know he had colon cancer. But he's unfortunately a good example of someone who developed a cancer that we typically associate with 50, 60, or 70 occurring at 43. And that has implications because a couple of years ago, as I'll mention later, we changed our cancer screening for colon cancer. It now begins at 45 and not 50 years because we're seeing this much higher incidence of colon cancer in younger people. We don't really know what's contributing to this. There are a lot of things in our environment that we learn about 10, 15, 20 years later. I grabbed a Diet Coke, and yet, there's now some concerns that the sweetener in our drinks are carcinogenic, xylenes in particular. I was listening to an interview on NPR last night, and they were interviewing an actress and her mother. And her mother was Diane Ladd, a very famous actress in her own life. She was a very natural, clean living person. She moved to Nebraska so she could live the way she wanted and, resource her foods naturally and whatnot. It turned out Nebraska, like all of our industrial farming belts, is loaded with fertilizers. And she developed, she doesn't have cancer, she has pulmonary disease and a short time to survive. But, they were emphasizing yesterday that they thought they had made a lifestyle choice to live away from pollution. But, we are so interconnected with our environment in ways that we don't appreciate. And so one of the things that's thought is that diet is really important with colon cancer. The microbiome, which I know, Michael, you've had people here speak about, our gut bacteria and the health of our gut bacteria can promote cancer too. And so people are on antibiotics, people are on chemo, people who are under stress, which changes our microbiota, can all promote cancer. And that may be one of the reasons we see it in younger people. And again, just in the last year and a half, screening for colon cancer was switched from 50 down to 45, recognizing that reality.
45 is enough. I mean, he died at 43. I was just thinking of the example there.
Yeah. So, it probably needs to be more selective and more targeted. It's still rare to get it at 45, but I have a colleague, Bruce Lin, he sees a lot of an Asian population, and he sees only colon and GI cancers. And I'm always horrified when he's out of town and I'm covering his practice, because I will see plenty of kids in their 20s and 30s who have advanced cancer. We're also seeing that in certain populations with lung cancer who've never been smokers. So a perfect example would be Korean women, for whatever reason, probably because of mutational burden that they carry, have a much higher incidence of lung cancer. Again, those are non-smokers. So when we talk about universal versus selective screening in a minute, what we really need are better tools to identify those who are at higher risk. And, we don't have them very well yet, but those tumor profiles from the blood are going to make a big difference in the very near future. You guys, this is a slide you've seen over and over again, and it's really just showing that over time, the types of cancers seen with HIV have changed. And we now see non-AIDS defining cancers, which are just cancers that really have not much or nothing to do with HIV, but have to do with aging and lifestyle and risk factors. So, you know, a non-AIDS defining cancer would be lung cancer or breast cancer or colon cancer. And an AIDS defining cancer would be cervical cancer, Kaposi sarcoma, non-Hodgkin's lymphoma, and if you want to call it separate, primary brain cancer. Those cancers have fallen dramatically, particularly in the US where we have such good access to ART. In other parts of the world that may not be that way. In third world countries that don't have access to ART, HIV-related cancers or AIDS defining are by far and away more important. And this is a slide that, again, doesn't project well for you guys there, but it basically just looks at what are the risk factors for cancer and what types of cancer it promotes. So as you can imagine, smoking is associated with lung cancer. In truth, smoking is associated with every type of cancer that goes from the lip all the way down the esophagus, into the stomach and into the intestines, and of course into lungs, because the carcinogens that you inhale get distributed down your alimentary tract and also the lungs. Alcohol is a potent potentiator of cancer risk, particularly if coupled with smoking. You know, we don't have good information yet about which recreational drugs can cause cancer. I don't know about you and your friends, but in my clinic, I've had people who've been my patients for the 33 years I've been in Seattle. But in the last 3 years, I've had a large number who've died rather suddenly, sometimes mysteriously. And in almost all instances, it's related to recreational drug use and getting, I suspect, something they didn't know they were taking. Yeah.
What are the 3 columns?
So the one, if I, yeah.
Yeah.
So the risk factor, so HIV replication, that only affects HIV. And, you know, that's goes with what kinds of cancers are associated with HIV. Immunodeficiency, tobacco smoking, Epstein-Barr virus, EBV, HPV, which we'll talk a little bit, cervical, anal cancers, oropharynx cancers, hepatitis B and C cause liver cancer, alcohol, liver cancer, and probably other GI cancers, and low body mass. And that's what I talked about, you know, people who have wasting, and esophageal and pancreas are good examples of this. So those are not wasting because of the cancer. It's wasting for other reasons and the promotion of cancer.
And I'll make a PDF of these slides we can have them for later.
Okay.
Okay, so don't worry about not being able to see it. I'm sorry.
Yeah, I think, you know, the one part, oh, thank you. The one thing I wanted to show were the, you know, these little pictures on the left. So that's pollution right there. And a couple of months ago, I was in India to give a talk, and I just couldn't imagine living there every day because the pollution is so thick. And the Washington Post had a really good article about the time I was doing it, talking about the risk of pollution in a way that we don't always associate with it. That's supposed to be a schemata of a virus in this case. I think that's HPV.
Yeah.
I can't remember. That's a cigarette. no. And then no, it's a dog. So yeah, right. You know, so this is a slide that just emphasizes a different thing. We think of HPV as just causing anal cancer or cervical cancer, and you can really see how strongly linked 95% of these cancers are related specifically to HPV. But there are other types too. And, you know, speaking of celebrities, Michael Douglas got head and neck cancer. and it was HPV associated. And he spent a lot of time emphasizing that HPV can cause head and neck cancer too. Interestingly, or perhaps luckily or fortuitously, HPV cancer of the head and neck is better than head and neck cancer without HPV. It's easier to treat for whatever reason. And it counts for about 30%. And so as we now are beginning to make sure what type of cancer people have of the head and neck, we can sometimes de-escalate the treatment, give them less toxic things to cure them of their cancer.
Does the HPV vaccine prevent most all of this?
Yeah, it has the potential to do that. So when I was in India, they can't afford the HPV vaccine. In the US, it costs, I know this now, $260 for a 2-dose shot. And it will be covered on insurance, but in India, they don't have it. India was the first country to market and make generic HIV meds. And that changed India's trajectory completely. People with HIV in India have access to these drugs, and the state will pay for it, and they're very cheap. When I was there, they were celebrating because they had just developed an HPV vaccine that was going to cost $3.
Wow.
So one of the big initiatives of the World Health Organization is to make sure every girl is vaccinated in childhood. And they feel that that's so much more important than boys right now because of the risk of cervical cancer. So their first target is getting young girls vaccinated and later young boys. So these are risk factors for anal cancer and cervical cancer. And because it's the same virus, because under the microscope, these are really very similar cancers and have very similar natural histories, no surprise, the risk factors are the same. And we know there are certain strains of HPV that are tumor specific or oncogenic more so than others. Many HPVs have no concern whatsoever. They can cause a little wart on the finger. Yeah.
What you just said, that you tell these differences, is this something that they can tell us now?
Yes, they would have to do like if you had a wart, they would do a biopsy and they could type it out. In truth, because like warts on your hands or on your feet are associated with non-oncogenic strains, they don't bother to test it. But if a woman is getting a pap test, they will do it. For a lot of the HRA tests that are going on now, they're typing the HPV as well.
I've had
And the
something like that twice that were HPV related, and the doctor at the time said, there's no, of course, no records of it. I'm just kind of curious, like how many times you can have these things removed.
Yeah, I think you could ask Jeff Shouden that. And if it comes to the anus or the cervix, you have kind of a lifetime risk of continuing to have these things come back. And that's why surveillance becomes so important. With head and neck, that's usually not the case, And so it's a little bit different, and the types of cancer is a little bit different too.
Someone just signed it. Where is that? There we go.
Okay, thank you. So Michael, I'm not getting it to advance.
Probably, sorry,
Okay.
Just 'cause someone signed in, so we just have to get that back here, and then there you go, and then you want to go forward?
Yeah.
Yeah. Oh, just hit the the space bar.
Okay. So, in the US, we have several vaccines available. The one that is most commonly used now is Gardasil. Gardasil protects against 9 different strains of HPV. And a couple of those strains are the ones most relevant for cancer protection. And so young girls should be getting this routinely. There's been a tremendous amount of misinformation about HPV and vaccines and what it can do. I forget the gal's name, but she used to be a Playboy bunny, and an actress, Jennifer McCarthy, had written a book about her autistic children, and she blamed it on the vaccine. And that created a huge panic, which still is in our subliminal conscious these many years later. But I think what's encouraging is if you look at that statistic there, they're finding that the uptake of vaccines is going up in the US, despite a lot of resistance on certain areas. So I remember when our kids were little, we sent them to the doc and they got their HPV vaccines. They were 2 boys and they were 9 years old or 11 years old when they got it. Something that I don't think much about, I like to be out in the sun. I usually have a suntan in the summer, is melanoma and skin cancer. My oldest son just got married and his wife is a PA in a dermatology clinic, and she's constantly harassing me about wearing sunscreen and the like. And of course she's right. The risk of skin cancers is substantial in the context of UV radiation. Usually we don't think much of skin cancer. They're squamous cells or they're basal cells. They're treated with either liquid nitrogen, they're cut off. Sometimes if they're in delicate areas over the face or the ears or the nose, there's a technique called Mohs surgery where they're basically shaved off very carefully. But of course, melanoma is a big concern too. And melanoma is also linked to sun exposure. So that's something to be wary of. And we don't have screening issues currently, or we don't have screening guidelines for skin cancer, but those are being developed too, as we begin to think about how best to reduce the risk of another kind of cancer that's continuing to go upward. So cancer screening, we really want to get, the idea is not to wait till someone has the cancer to such a degree that they're having symptoms. Want to catch it before they lose weight, before there's a palpable mass, before it's had a chance to spread everywhere else. And the idea is that if we can catch a cancer early before it's had chances to go to other locations, far better opportunity to cure it, and not maybe in some instances not have to go through more painful or difficult treatments like chemotherapy. Universal screening is really when we say we're going to test everybody, and that might be everyone over 50 should get a colonoscopy, or every woman over 40, as opposed to selective screening, where when we talk about lung cancer, we're not saying we're going to screen everyone. We're going to take the people who we think are at highest risk, people who've been longtime smokers, people of a certain age, people who, if they stop smoking, stopped within a window. So we always think about this idea of, wouldn't it be nice if we could be perfectly selective? One of the risks and one of the issues which comes up is that, you know, in the winter, I'll spend a week in Palm Springs for vacation, and you'll see these billboards that, you know, they're catering to an older population. They'll say, CT PET scans to screen for cancer, you know, and these are not things that insurance will cover. But for $700 to $2,000, you can get one of these scans. And they are very powerful, and they can pick up things that you wouldn't otherwise know. The problem is they pick up a lot of things that aren't cancer too. And sometimes we cause more problems trying to remove or to biopsy something that really is not cancer. And so the other part of it is that we want to get really good screening tests. And if we don't have a treatment for the cancer, there's no point to test for it. So in a lot of, you know, places where, you know, Jeff and others have been participating in the anal cancer screening study, but in parts of the country where they have no facility to do those kind of tests, we're not pushing them to do that kind of a test. And again, you need local expertise, and you have to be screening for something that's curable. We don't screen for leukemia. We don't have a way to prevent that at this point. So this is just a slide, and it kind of shows what cancers people with HIV are more likely to get than the general population. So lung cancer would be one, lymphoma would be another. Oddly, there are some cancers where the risk looks to be smaller. One of them is prostate cancer. Another one is colon cancer. And it's not necessarily because those are inherently less risky, or breast cancer is less risky. It's that we don't do a good job of screening our HIV population for those cancers. So these are things to keep in mind. And so one of the questions that comes up is, should people with HIV be screened at a younger age if they're at higher risk for cancers? Should they be screened more frequently? Should we be doing different tests? And are there certain cancers that should be screening in people with HIV that we don't screen in the general population? And again, as we think about different populations with different risks, these could be more generalizable questions too. So I'll spend a minute just on cervical cancer. And one of the things that it kind of caught my attention as I was going to India to give a talk about cancer is that 15 to 20% of all the cancers in the world are associated with HIV. That is just a staggering number. And by far and away, the largest area or concentration of cervical cancer is in Africa. And in that area where in some areas, 40% of the population, or as many as that, 30 to 40% are HIV positive, but it's a huge cancer burden. In the US, cervical cancer, fortunately, is not that high because we've developed really robust screening, a pap smear, a gynecologist visit. HPV vaccines will have an impact over time. The World Health Organization has tried to develop standards for HPV testing, cervical pap smears for women, and that's really where they're putting their energy right now. There is such a dearth of good gynecologic care. There's so little screening among women. It's just a terrible cancer to develop. So as I said, their major thrust right now is to get HPV vaccines into little kids as the first beginning, trying to make an impact over time. This is a slide that Jeff and I have used before for anchor study stuff, and it just talks about the higher risk of anal cancer in HIV plus people, men and women, and that despite the use of HIV meds, that rate hasn't changed dramatically. There is more recent data suggesting maybe HIV meds do make a difference in the risk of anal cancer, but it's not profound, and we still say this is a really important area, a high-risk area, where there's a lot of research being devoted. And a common question I'll throw at you, can you be at risk for anal cancer, even if you've not had anal sex? Michael, what do you think?
I would say yes.
Yeah, anyone disagree? No, okay. I think they've learned not to disagree with you over time. But yes, that's right. Because we think of HPV as a field effect, and you could have, more traditional anal cervix sex, but HPV travels around the genital and anal area. So it's a really field effect. And so yes, anyone and all of us who are sexually active would be at risk. Yeah.
So, is it the actual sex act that they think might be causing the cancer?
It's not the sex act itself. If both participants didn't have HPV, there'd be no risk for cancer. It's the spreading of HPV. And then this notion that, with HIV, your immunodeficiency is such that you don't clear the virus that you pick just as well. So, there'd been a lot of concern with anal sex that there's a higher risk of acquiring HIV because of mucosal breakdown and irritation. But in terms of risk for cancer, it's not the sex act itself. It's the transmission of HPV in close skin-to-skin contact. Okay, so this is, I think, a little bit of a slide that just talks about how with HPV of the cervix or the anal canal, there's a gradual change in the types of cells there. And if you look at the far left, those are cells that are really healthy, and they look very bright and they have a small nucleus. And as the mucosa becomes more inflamed and changed over time with HPV, you see these smaller cells that have a bigger nucleus, a darker spot in the middle, and less cytoplasm. And over time, if you look in the bottom right-hand corner, the notion is that there can be a perforation or a break in the basement membrane of the skin and the mucosa, and that can allow what are emerging cancer cells to go into the circulation. So we think that those high-grade changes that were on the far left of your screen are the things that can be at risk for promoting cancer. And when people like Jeff Shouden are doing HRA tests, they're doing pap smears, they're doing visual inspection, but they're trying to find the areas that are the most ugly looking, the most dysplastic. And the notion is to treat them before they have a chance to become invasive or develop into cancer. So I think, has anyone participate here? I know a couple of you have been on Anchor. Peter, I know you were actually a chair. I can't remember.
Yeah.
Yes. Right.
Yeah.
Right. Well, I mean, people who've gone through this know it really well. It's very similar to what a woman undergoes with a cervical thing. We take a swab, we rub it around the rectum, we collect the cells. Those are what the pathologist looks at. If it's a man, there's a rectal exam, and the idea is to also ideally palpate the prostate, feel for irregularities around the anal mucosa, and then there's the inspection and biopsy with a scope. And a lot of people that I'm talking to, it's hard for me to get them into the HRA clinic. They're resistant, they don't like it. You can all imagine reasons why people aren't rushing to get their butt, examined like that. And a lot of people are under the misinformation that if they had a clean colonoscopy, then they're good. And, I've been amazed now because our GI docs actually say how long it took them to do a colonoscopy. And, it used to be they'd be taking 20 minutes. It's like 6 or 7 minutes. And the colon is like 30 feet long or longer than that. And they're going through and they're just looking for really obvious things like a polyp to biopsy, an area that might be bleeding because of an erosion or an abnormal blood vessel. By the time they get to the anal area, which is 1/4 of an inch, it's like the thing is out. And unless this was a really big fungating abnormality, they will not notice anal cancer. And so these are very different things, and it often takes a little bit of explanation to get people to agree to this. So again, this is what someone like Jeff might see if he's doing an anal exam. This wouldn't be much different to what a GYN doc does with their colposcope. And the areas that are most suspicious would be the areas that are biopsied. And on this slide, that area on the top that's white is the area that's suspicious. That's the area that's going to get biopsied. There are a bunch of ways to treat this, and one is surgery. And back in the day when we first started an anal dysplasia clinic, this was with a nurse practitioner named Lacey Sekas. She would do the biopsies, they'd come back abnormal. We'd send folks to the surgeons and they would, carve these areas out. Incredibly painful. People would do it once and they would never go back again. And luckily, there are better techniques today. They're not perfect because these areas can keep coming back. They have to keep being looked at. But using topical agents is one way. Using electrocautery or infrared coagulation is another. And again, monitoring these areas, treating a pre-cancer before it becomes a cancer. I don't want to spend a lot of time on this. Jeff has spoken many times to the CAB. I have too. But the Anchor study was stopped last year. The DSMB, the group that looks to make sure that there are no harms being done, was reviewing that, and they said, we've gone far enough. we've identified clearly that this is beneficial, and it's no longer ethical to randomize people to be monitored without getting treated. And that was a huge thing. And as I mentioned before, this was selective screening. They were taking people older than 35 or older, because they thought the risk of defining an anal cancer was going to be so small in a younger population. It takes many years of this kind of changes to the epithelium before cancer typically occurs. And, what they found was that there was a significant reduction in the risk of anal cancer in those who were getting treated. This was a study that divided people into getting screened and monitored, or getting screened and treated. And the group that were getting treated had a much lesser risk, 57% less risk of anal cancer. It's the same principle that goes with cervical screens too. That the gynecologists can do what's called the LEAP procedure, where they remove a small amount of the cervix surface where there's cancer and prevent the cancer from growing and becoming invasive. So who to screen for anal dysplasia? This is what we're doing at VM. And in truth, we talk about immunosuppressed patients. These could be renal patients who are on a lot of, renal transplant patients who's on immunosuppressive therapy. It could be a patient with severe rheumatoid arthritis who's on a biological agent. It could be other folks. But really, in our clinics, it's mostly HIV. This information hasn't really been generalized very well to other groups. And of course, Anchor showed a reduction in cancer, but they were only looking at HIV positive people. Not really a good reason to think it wouldn't be different from other people too. So in this group, we say men who have sex with men should do it even if they're HIV negative, because it's HPV that's the risk factor there. And then we say anyone who's HIV positive should be tested. So that is men and women both. And then patients who've had cervical, vulvar, penile, we talked about this being a field effect. So it doesn't just confine itself to the anus. And if you've had cancer in other areas, then you're at high risk for that too. And then, people who have pain or bleeding, 99% of the time, it's not anal cancer. It's going to be a hemorrhoid. It's going to be a fissure. It's going to be something else. But those are the things that we just say, don't ignore it, get it checked out. Let's be sure of what it is and treat whatever it is. So there were limitations to the Anchor study. And this means that this is not a perfect study. It made a couple of findings, but it didn't give a really practical way to do these screens. So we're lucky, we're in Seattle, we have a number of people who know how to do these careful anal exams. Most people do not. General surgeons haven't been trained in this way. They are not going to be able to do the really fine and meticulous job that people who've gone through screening for this. The other thing is that I said rather casually that we should be able to generalize this to other populations. But, many times we make assumptions and then the clinical trials prove us wrong. And this hasn't been studied in other populations to this degree. And then, this is a really expensive endeavor. It takes time for the person to get the test. So it's their time and their inconvenience of coming in. There aren't many people who are well trained to do this. The setup, the technique, the assistance that you need, it's a lot of money. Most centers are not or haven't shown an interest in really developing the infrastructure for it. And again, maybe this will become really easy. For cervical cancer, people are doing home pap smears and mailing them in. There's similar technology going on with anal pap smears too, where people can be trained to do it. And that is a promising area in a low resource area of maybe who you say, okay, you have an abnormal cytology, come on in. It doesn't mean you have cancer, but we're going to be selective and we're going to try to get the people who are most unusual. Yeah, Mike.
I just wanted, since you were bringing it up, I just wanted to say, from my limited perspective, I think like Jeff Shelton, when he stepped forward to take on that training, like we are lucky in Seattle that we had someone with enough perspicacity to see far enough into the future to have that take on. So we have anal dysplasia clinics at Harborview that people can do. And, like, I think that just points out how much other areas don't have these type of doctors.
So Jeff should get a Lifetime Achievement Award. I really believe it. He has been amazing. He was at one time a surgeon. Later, he was a community advisory board member. He came up with he got his law degree. He produced some very important information for CABs and how to review studies, what are the responsibilities. He reinvented himself as a world authority on anal cancer screening, and he was instrumental at Harborview. That was been an uphill thing. He was instrumental at our site too. He was doing anchor for us at Virginia Mason. And he's still doing stuff, and I think we still rely on his knowledge and expertise. So I totally agree with you. Switching gears for a minute, this is colon cancer. And again, we talk about the fact that this starts as a polyp before it becomes a colon cancer. It takes years typically for a polyp to emerge into colon cancer. And the idea is that if you could find that polyp before it turns into cancer, you can save that person from a cancer diagnosis and cancer treatment. Age is a big issue now, and we're seeing this much more frequently. It is thought to be related to our national epidemic of obesity. And we see colon cancer increasing, particularly in the US. And there may be, again, ill-defined environmental factors, food additives that make a big difference. We know that high fiber diets make a huge difference. We talk about cancer risks in different countries. In Africa, the risk of colon cancer is almost zero. It's very, very rare. They also eat high fiber diets that are completely different than our processed food here. And this is just a slide showing that there are different ways that you can screen for colon cancer. And when we talk about these things, you've all seen commercials for Cologuard. Cologuard is a pretty cool thing because it's looking at stool DNA. It's not a blood test looking for blood in the stool. It's actually looking at tumor DNA. And it's a way to screen for colon cancer. And for people who can't or won't or are unable to be screened in a conventional way with colonoscopy, that's a viable option. For colonoscopy, it's really inconvenient. You have to take off from work because they don't work, they're doing it Monday through Friday. You have to take this really horrible salty stuff and drink like 2 gallons of it to clear your bowels up. You also have to have someone to take you home if you're going to get the colonoscopy. And that's sometimes the biggest issue. People don't have friends or family who can take them. And these places will not rely on an Uber driver to do it. So there are a lot of barriers to this kind of thing. And again, how nice to have a super duper DNA test, either from stool or from blood or from a swab to do all this stuff. And there are, robust research looking at swabs from anal areas for HPV and precancerous changes in the molecular profile that can be done. And so that really, when we think about where HPV screening will go or anal cancer screening, it's going to be hard to do what Jeff and others have been doing in the long term. We need a better solution than that.
There are so many men in Seattle that can't get their colonoscopy because they don't have anyone to escort them home. And I've been pushing for them just to admit them for one night.
Yeah. So that would be a solution. But I can tell you that hospital administrators are desperately trying to keep people out of the hospital. We have so many people in our ERs that need to come in. So things that we used to bring people in for, and sometimes we do, people have other comorbidities, they can't, just do a colonoscopy and go home. But the challenge is that we have 200 people in the ER also needing those beds, and they need to come in. And insurance isn't covering those kind of admissions, And so suddenly that cost will get put back on you, when your insurance says, we're not going to pay for it, So it is a huge problem. I know that in the cancer field, we have American Cancer Society, and they have a series of volunteers who will drive people in and back to their chemotherapy appointments. And they have, they do fundraisers to pay those kind of things. We don't have it for colon cancer screening, but we should, and that's something that individual cancer centers are beginning to advocate for. The other thing, and I know you guys heard the talk about lung cancer screening. This is a really important area. Smoking is overrepresented in folks who are HIV positive. The risk of lung cancer in people who smoke and are HIV positive is much higher than the general population. And there are multiple reasons for that. But we do think that HIV causes inflammation in the lung or has the potential for. And so it's not just the act of smoking, it's the synergy of having HIV as well. I don't know, and I don't know if the speaker last month, Michael, talked about whether HWART has much impact in that.
No.
I doubt they do, but there hasn't been much research. And then, the other thing is that we talk about people getting cancer at younger ages. In 2021, lung cancer screening guidelines changed, and it went from 55 to do a CT scan of the lung down to 50. And again, it's with this recognition that people who are smokers have such a higher risk of cancer. And it took many years to get this approved. But we found that, this low dose CT scan, so it's without contrast, it has much less risk of radiation exposure, can pick up these cancers at a very early stage before they've had a chance to go to other locations. And again, you can see here recommendations around that. And, the AMC or the AIDS Malignancy Consortium is going to be gearing up to do a lung cancer screening study in HIV. Mm-hmm. And, we don't have very good data about lung cancer screening in HIV for a couple reasons. One is the original studies that looked to show that CT scans were helpful were very carefully selected which population they wanted, because they didn't want people who had tuberculosis or fungal infections or scarring in the lungs to confuse what was cancer for not. So they had a pretty pristine group of people who were just smokers, and they purposely excluded HIV as one of the criteria. And when we talk about treatment of HIV and cancers, there's so little known because most of the trials that incorporate cancer treatment exclude HIV. And I'll spend maybe a minute with that in a couple. But this is a study that the AIDS Malignancy Consortium is doing. It's specifically looking at people who've been long-term smokers who are HIV positive. And it's really a two process. One is to see if lung cancer screening is feasible and effective. How many cancers will we pick up? What will we do with the natural history? People on it can continue to receive things that help them stop smoking. So like Zyban or, Wellbutrin or nicotine patches or other things to help them with their smoking. But it also has a really cool app that takes you through 8 steps or 8 different learning modules, which incorporates behavior modification. And it's really looking to see above and beyond the lung cancer screening, are these modules helpful in getting people to stop smoking? So it's not really just to pick up cancer, it's really to help them stop smoking.
David, will that study be done here?
I don't think so, because we don't, AMC was very briefly a presence here at Harborview.
Right.
And unfortunately, the funding wasn't carried over. So it will be at Virginia Mason.
Okay.
And it'll be at other places across the country. It has to be in centers. And of course, you guys have it. but areas of lung cancer screening. So
But people could still go to Virginia Mason if they wanted to participate.
absolutely. And I think, I think Rachel's, on the call still, but I think it's in the process of going through our IRB. We're getting our mechanics worked out.
Great.
We're hoping that in maybe the next month or two, we'll be starting to enroll people in the study. It's a no-brainer of a study. And Rachel's going to kick me, but I think that it does pay $100 for your participation, really for the nuisance of coming in, filling out forms, being willing to do the study.
Excuse me, I have a quick question.
Yeah.
I do not smoke, but I know lots of people who do. What is the status of, I have repeatedly heard that psychedelics treatment, basically one or two psychedelic treatment with a properly trained therapist can completely eliminate smoking. And the military is using psychedelics actually for PTSD treatment. And I wondered if you had any comments on that.
Yeah, I think so. There are a lot of things in the world of psychiatry and behavioral medicine that are still kind of on the cutting edge. This is one of them. And psychedelics used for treatment of post-traumatic stress disorder looks like a really promising area. And it doesn't take a lot of imagination to think how certain areas of our frontal lobe that control craving and urges and stuff could be modified with medication, whether that medication is a psychotropic or a plant-based edible or something else. So I haven't seen the research specifically for stopping smoking, but we know this works, or it's a very interesting and hot area for a lot of different areas. Did that answer your question?
Yes, but I was actually wondering if any research is being done specifically on smoking cessation in the U.S. From what I hear, people are traveling outside the U.S. To do this because psychedelics are heavily restricted by the U.S. government, and getting research with them is quite difficult.
Yeah, I'm not aware of research in that area specifically for stopping smoking, but it's being used for like obsessive compulsive disorder and other things. So I'm sure that it's out there, but you're right. I don't know of any place in the US that is doing that kind of research. So one of the things I'll just point out on this slide is that what we found is that people who participate in lung cancer screening also have just doing that screening is a really positive and affirmative action. And in itself, that has allowed people to reduce their smoking and stop smoking. Use of drugs like Wellbutrin and Zyban can be very helpful if they're not perfect, obviously. And vaping for some is a crutch to get them over the top too. So I think our study, or this study from the AMC, will be looking at that. Now, just a couple things. Cancer disparities and HIV are huge. I mentioned before there's statistically a lesser risk of breast cancer and prostate cancer. Interestingly, prostate cancer in men is the #1 cancer as we get older. And by 2030, it's estimated that prostate cancer will be the #1 cancer in those with HIV infection. Not because HIV causes prostate cancer, but because they're getting older, and people in their 70s and 80s have much higher risk of prostate cancer. But we do a prostate cancer of the prostate. Yeah. But we do a very bad job of screening for prostate. We don't have good algorithms for it. The same is true for women with breast cancer. Statistically, less women with HIV have it, but in areas of the country or clinics where mammograms are done, it looks to be about the same, not higher or less.
Excuse me, a comment on prostate cancer. I discovered in 2006, there was a researcher named Dean Ornish. He did a small 16-minute TED discussion, which you can find, do Dean Ornish TED. He found out he can basically reverse prostate cancer, stop and even reverse prostate cancer. and they did actually internal scans, and so they could watch the progression of this. And they did this simply with a change in diet. It was largely a vegetarian diet, but they did use put skim milk in there to keep people from eating the diet. But essentially, if you go on a plant-based diet, you can reverse prostate cancer, and it is much more efficient than having surgical intervention, which has a very high probability, either surgery or the radioactive pellet, which can cause impotence in men. And yes, it is also related to breast cancer, but he did no research on that. But this has been known since 2006, that a change in diet.
Yeah, so I won't refute it, but I'll just tell you an interesting story. Years ago, I was listening to NPR, and Terry Gross was interviewing Linus Pauling. Linus Pauling is one of the most brilliant humans who ever lived. He's the only guy who won 2 Nobel Prizes in 2 completely different fields. He was obsessed with vitamin C. He discovered the crystalline structure, and he won a Nobel Prize. And then he got another Nobel Prize for his research in DNA. And later in life, he developed, so because he was such an important figure, the first randomized trial for colon cancer was a trial where they gave people vitamin C or placebo. And it was his very strong contention that vitamin C could cure cancer or reverse cancer. And there wasn't a lot of proof to it, but because he was such a prominent person in this field, that was the very first randomized clinical trial in 1960. And it did not show a benefit. So keep that in mind.
Correct.
Wait,
Correct.
I'm not arguing with you, but hold on just a second.
Okay.
30 years later, he's being interviewed by Terry Gross. He's now 92 years old. He has prostate cancer, and he has a short time to live. And Terry Gross is a brand new person on NPR. She's pretty timid in those days. And she's asking this very gruff guy about his research in vitamin C, and he's waxing on and on about it. And finally, she gets to this really delicate question. She goes, Dr. Pauling, if I can ask you, if vitamin C is such a great panacea for cancer, how come you have pancreatic cancer? How come you have prostate cancer? And he goes, God damn it, woman. If I knew what I knew now when I was 30 and I'd been taking vitamin C my whole life, I wouldn't have prostate cancer. And those it was a brilliant answer. And I remember at the time just pulling over to the side of the road to reflect on it. But it's impossible to prove and impossible to disprove. So I'm not arguing with you about, Dean Ornish,
Well,
but rather,
I do know about Linus Pauling.
Just a second. Hold on.
Okay, I just want to continue.
Hold on just a second.
Respond to your Linus Pauling.
Okay, well, I'll give you a sec. But what I'm saying is that it's not that we can prove that cancer is regressed, but certainly certain diets can reduce the risk of cancer. And that's what I would tell to the group, not that you can reverse cancer with a diet. There may be things that can change, but usually by the time you have the cancer, the cat is out the bag. Anyways, go ahead. I didn't mean to interrupt you.
Okay. Linus Pauling also claimed that he could live forever because of vitamin C. He definitely overstepped his bounds, but even despite the 2 Nobel Prizes. But Dean Ornish has radiographic evidence. They put him in, I don't know which technique they used, but they could simply watch the prostate reduce in size on his treatment program. So Dean Ornish from 2006 does have evidence in men that a change in diet, going to a plant-based diet essentially, can reverse prostate cancer. And I should mention, I read I saw a YouTube video many, many years ago, and there was the actor back in the 1930s. Anyway, now I can't remember. Fatty Arbuckle, correct. Fatty Arbuckle was diagnosed with cancer, got treated, and Fatty Arbuckle was quite fat, and there was also a sex scandal involved later on. But back in the 1930s, 1940s, and they had huge, giant radiation machines, which look like they're out of a science fiction movie. They were bulbous and, you know, um, they put him when he recovered after the treatment to prevent his cancer from coming back. They basically put him on a diet of rice and beans and vegetables to prevent the cancer from reoccurring. My sister actually just had her uterus removed 2 years ago, and I was very surprised to find out that they were advocating more plants in your diet, but they wouldn't say less meat. And was also interesting, they also recommended meditation for cancer recovery, which was amusing. But back in the 1930s, they didn't know that a plant-based
Hey, wait a second, wait a
I'll
second.
stop.
Time out. I'm gonna have
Okay,
to stop you because I gotta finish. But I appreciate the points that you're making, which are that diet has a huge influence on risk of cancer, whether it can cause cancer to regress. You've given a couple good examples. So thank you for sharing that. And I totally agree that diet is important and we don't understand it very well. And it's going to take a much bigger focus and research coming up to, I think, as you say, it will help us move that area along.
We actually do understand it quite well.
Okay, well, you do, but I don't.
The food industry
Time
has
out,
been,
time out.
yeah,
I'm going to have
I'll
to.
stop.
Yeah,
Yeah,
thank
I'll
you. Okay.
stay quiet now.
All right, thank you. So anyways, when we talk about cancer disparities, we talk about people with HIV having survival rates when they do get cancer that are not as good as those who don't. People with HIV are 4 times less likely to get treated for cancer, and factors associated with low likelihood of getting treated have to do with access to care. And we can think about that as we learn through COVID about such huge disparities in care and what the implications are. There's still a lot of misinformation out there. People, physicians who think that because someone is HIV positive, they can't tolerate the same treatments. And there are also people who don't understand the interactions between HIV meds and chemotherapy, which can cause a lot of toxicity. And yet we have so many drugs at our disposal that we can switch those things around. So I don't want to belabor the idea of cancer health disparities, but it's a huge one. And in cancer care, as in HIV, that's really true. And this is just a simple slide that shows lesser survival with certain cancers in the context of HIV and not. And again, probably because of poor access to care, misinformation about what people can tolerate and what they can't, the notion that people who are HIV positive are just excluded from clinical trial participation are all really important features. I think all of you know about some really groundbreaking work of several people who've been cured of cancer. And Michael, you've done so much around this, who were also cured of their HIV. Timothy Brown is, of course, our local product that we take so much pride with. Croy was probably about 8 months ago now, and they had a patient from Chicago that was presented there. There's a famous patient from Germany also. And the idea is that these were people who were able to get chemotherapy, but in the process, clear their reserves of HIV. It's an incredibly dynamic field. It's an incredibly important field. Obviously, people can't get high-dose chemotherapy and transplants. You know, many of them die, but the technology and the way to do this is being scaled in a different way, where we'll be able to take blood from them, grow certain cells in a container, put it back in them, and help them fight both the HIV and their underlying cancer. So when we talk about treatments, it's really quite remarkable. This slide is one of my favorites. It's a before and after slide of a guy before and after HIV meds. And this was taken like 20 years ago, just as the cocktails were being introduced in Africa. And just incredible. And we have so many different meds now. The vast majority of people who are taking them are non-detectable. And we're learning to be very clever about switching meds out in the context of adverse effects with chemotherapy. So those are important areas where we're studying kinetics, understanding what people can take, what they can't, and how it influenced their chemotherapy treatment. I think one of the challenges is that as we think about this from a social perspective, we have amazing treatments that are at our disposal, but our healthcare system is so broken, people can't get in the door to get those treatments. They can't get the proper screening to prevent the cancers to begin with. And those who are diagnosed and who have insurance still may not be able to pay for the treatments that they do. Most of the cancers I treat are blood cancers. Those that are treated with pills like chronic myelogenous leukemia, one pill a day costs $20,000 a month. Who can afford that? So this is just a slide, just in a very general way, saying that there are cancer-specific issues, there are HIV-specific issues that we all have to take into consideration when we put someone through a journey of recommending a treatment. And I agree with the speaker in the audience, diet is really important. So, I'm not arguing, I agree with that 100%. I think Jimmy Carter is a poster boy in a lot of different ways. I mean, he had an imperfect presidency. He didn't win his reelection. For many years, he was ridiculed, but he spent the next 30 years of his life being like this amazing humanitarian who did so much for the world. It's just heartbreaking to know that he's on hospice and dying now. But I show this picture of him because about 10 years ago, he was diagnosed with melanoma. And that melanoma involved his liver and his brain. And the average survival of people with melanoma was about 3 months in those days. And he got this stuff called checkpoint inhibitors and immune checkpoint inhibitors. And his cancer went completely into remission. And he's on hospice now, which I think is, this sounds weird, but I think he's such a good person. He wants to be an example and let the world know what hospice is really about. But he's not dying from melanoma. He's just dying of old age. And he got these therapies and his melanoma was cured. Years ago, I saw this kid who in high school developed a melanoma and it had traveled to his neck. He had surgery and was removed. In those days, we didn't have anything. He went to college. And after he just graduated from college, he and his dad took a bicycle ride, the Seattle to Portland bike ride. He got sick when he got to Portland. He ended up in an ER and he had cancer all through his body, including his liver. He had just graduated. He was doing an internship for his first job. He was having a 2-month internship. He got the same therapy that Jimmy Carter did. He also had brain and liver metastases. And he's now 30 years old, and he works as a radiology technician at Virginia Mason. And it is just stunning to see what checkpoint inhibitor therapy can do.
That kind of treatment's not available to Medicaid patients.
It is. So checkpoint inhibitors are available. They're Medicaid approved, and you can get them. And so these therapies are available. And the other thing I was going to say was that for a long, long time, they weren't available to HIV positive people. And all the trials, again, excluded HIV. And it wasn't that people are evil and they're purposely excluding. They're saying, oh, this is a new drug. We can't afford any mishap. We got to show positive results. And we're worried that we're messing with the immune system. People with HIV may not do this as well. We're going to exclude them. It's trying to sugarcoat the study, get the best participants in so you can get the best results. And more recently in Harborview, I think Rachel had done a study looking at a review of the literature showing that people with HIV do just as well. And last month, there was a study in our oncology journal of a very large cohort of HIV folks who were getting immune checkpoint inhibitors for all kinds of different cancers, including lung cancer, including melanoma, including Kaposi sarcoma, and they do very well with it. These drugs can be tricky. They can stimulate the immune system to start attacking yourself. But usually the idea is they stimulate the immune system to attack cancer cells. And when it works, it is really, really remarkable. And many of our patients with kidney cancer, with lung cancer, with now breast and ovarian cancer are getting these immune therapies rather than traditional chemos that cause hair loss, nausea, and vomiting. So just to kind of end this talk, what causes cancer? There are a lot of things. We think of environmental factors. If plant-based food can cure cancer, I don't know, but certainly taking plant-based food can prevent cancer. The challenge is, can you get food in our society that isn't contaminated in different ways? Cancer risk and aging is huge, and we're all, until COVID, we were a society that was living longer, and after COVID, the US survival rates are actually declining. You have to go to Japan and to Europe to get areas where survival keeps improving. Non-AIDS defining cancers are huge. Those are the ones that come from lifestyle choices, drinking, smoking, not eating the right foods or eating too much of foods, and being unlucky. Your area code can determine your survival. I'll give another example. I heard a great talk years ago from an African-American oncologist who works in the Chicago area. And he works on the South Side, or the worst area of Chicago in terms of resources and money. And what they showed was that if you lived on the South Side, your area code was X, your chance of surviving prostate cancer was worse than if you lived in a third world country, because men who are African-American don't get screened for prostate cancer. And when they do get it, they don't get treated well. And he compared that to the area code where Northwestern University is, which is a really Tony area. And of course, that's the best in the world because they have modern treatment there. And so I think COVID really shined a light on that, the access to care, the insurance that you have, your knowledge, your family, how you get that. One of the slides I mentioned was, it's like, I think that it's really important to get to know your provider. Or maybe a better way of saying is, it's better for him to get to know you so that they really take an interest in you. These days, people are running in and out of visits. I know you guys know this well. Everything is templated. We're writing on a computer, stuff and hardly paying attention. If you can stop the presses a little bit, get the people out of their little rituals so that they're paying attention to you, that's really good. It sounds terrible, but if your doctor likes you, your healthcare provider likes you, you're probably going to get, what's that? What's that? Yeah, right. We do have openings. But do I?
I'm absolutely serious. Do you have openings?
I see new patients every single day.
I have not been on HIV meds for almost 2 years. I couldn't get my records. I've been completely deleted. I've been moved up.
Well,
I have nowhere to go.
why don't we talk after the meeting? Okay. Hang over and I'll come and we'll talk about it. But that is an issue. And I've had patients who've gone through similar things. And then I think that just the other thing is treatments for cancer are changing and changing in a radical way. When I was a new doctor, I remember meeting a kid who had testicular cancer. And testicular cancer is one of the most curable cancers there are. He was like 22 years old. It's a cancer of really young people. And he absolutely refused to get chemotherapy because the chemo caused horrific nausea and vomiting. And that wasn't something he was willing to put up with. We thought we could convince him, we never did. He died from this cancer, which 90% of the time, even 30 years ago, was curable. But nowadays, the anti-nausea meds, the supportive care we have are infinitely better. Many of the treatments like the immune therapies do not cause hair loss. So there's no stigma around it in those ways. We still do a crappy job in the US of screening for cancer, catching it early. But if we can, the likelihood of success is overwhelmingly high. The other thing I wanted to show you was just this, and I stole this from Michael. It grabbed my attention. So, I think that this whole area of LGBTQA is just such a hot spot of unfairness and horrific politics going on in the US right now. And I think of this as an area where people get terrible medical care, much like HIV did 30 years ago. There's so many analogies, and it's shocking to see the vitriol and the politics and, what our society is coming to. This caught my eye because they were asking for community advisory board members to participate in a study that really it's informational gathering. What are the challenges of getting people to be screened, to get treated, to get appropriate care? So I'm going to throw out another plug if there's anyone out there. Jeff years ago was a member of our community advisory board. We have like 2 people in our cab for the entire USA. We desperately need people. And this is, unfortunately, I noticed this pays money to be a part of, which our cab should be doing too. And I've made a proposition, but they don't right now. But if you're interested in this intersection of HIV and cancer, interested in clinical trials, I can give you a contact person. We're definitely looking for people. This is great. And then this one, you get paid $100 each time they bring you in for a meeting.
Right.
So Michael, you passed this out and it
Yeah, I
really
think
caught my
you got
attention.
in my emails, we've gotten an email about this one.